So in this, we will be talking about all the normal views. We will not talk about anything abnormal. Any congenital heart disease or abnormal views is in the different set of uh, presentations, and it's altogether a different ball game. So when we talk about the normal views in the normal assessment of various views indices, that's what we consider it as a functional focused ultrasound or focus echo. So this is there to support your clinical judgment and to improve your clinical diagnosis. So all these things, what we'll be doing in basically in NICU is for better outcome of the patient, and it helps you in augmentation of your clinical judgment. Right. It's getting this has been nomenclated as F echo, TN echo, and all, you know. So only thing I just want to bring about is that whenever you do the functional evaluation, either it can be hemodynamic problem or it can be anatomical problem. Whenever there is an anatomical problem, please never bypass the pediatric cardiologist. If it is a hemodynamic problem, structure is normal, then it is in your sphere. You can assess and deal with the problem. Like it is something like, you know, graphics on ventilator. With graphics on the ventilator, you will be able to do the ventilation precisely. So it optimizes your ventilation. Similarly, your hemodynamic assessments, functional assessments of the heart will optimize the hemodynamics of the baby. So now straight away, let's talk about the basic views. You must be seeing various views, all those things. All these views, we take it from the windows on the baby's chest. And that's why, you know, we have been talking about the phase array probe, the footprint is small, the ribs are there. So that's why conventionally the people with experience over the time have seen that that particular part of the heart is best visible from that particular window. So they have nomenclated those windows and designated that that particular images, views, and structures are best visible from that particular part of the heart, of the chest. And to know it, like which part, because whatever we will be seeing in the machine isn't two-dimensional, 2D, but the heart in the chest is not lying in two-dimension, it is a three-dimensional thing. So that's why we should be well versed with the anatomy, the relation of the various structures of the heart, anatomy of the heart, and orientation of the heart in the chest. So that is very important. So this I've just told you that various machines will have different buttons, but we should not be getting confused with that. Before we go to the various windows through which we see the various structures of the heart, we should make ourselves well aware with the basic echo machine screen. So that is very important. So this is how, because in echo we use phase array probe or the sectoral probe, and this is how the sectoral probe will look like on the screen, because this is like a sector. This yesterday Dr. Kamal has told you this is a probe orientation marker, and we will talk about this, and Dr. Kamal has very nicely explained that this corresponds to the probe marker on the probe. This is the scale will appear, and you will a color window on your study, whatever view you are doing. When you hit color, this color window will appear, and along with that, this scale, velocity scale will appear. So you should be aware that which structure you are doing this color Dopplers, and this scale should be adjusted as per the structure, like if you are doing a color window, you have put on arterial structure where there is arterial flow, then this has to be kept in the range of zero 0.7 to 0.8 meters per second. If you have kept it in the venous structure where there is a venous flow, then this has to be kept and adjusted in the range of 0.25 to 0.35 meters per second. This probe orientation marker on the echo screen, if you have selected cardiology, will always remain on the left side of the screen. This is right side of the screen. This is left side of the screen. This probe orientation marker is always on the left side of the screen, and this is by convention. The only thing that you can do with this is you can move up or you can move it down. So you can move it up and you can move it down. So you can do up and side, up and down, but it always remain on the left side of the screen. This you should remember, and it is by convention. This has been explained to you yesterday by Dr. Kamal. Okay, then this is the focus. Yesterday he was telling you regarding the focus, but this provision was not there in the Sonosite, but in all other machines it is there, and this has been explained to you by the Dr. Sajan in his first lecture, that is what this focus does. With focus, all if you adjust the focus in this particular area, what will happen? The ultrasonic waves which are being see here will be the probe, because probe orientation marker is here. So the ultrasonic waves will get concentrated in that particular area, and then after that they will diverge. So this area where the focus is being placed will be more clear and the resolution will be better in that area. So that is regarding your probe orientation marker, sector, focus. This one is the velocity scale. Here you will see there is a ECG tracing. Ideally, all echo studies are to be accompanied by the ECG tracing. But in practical, we don't do that because it takes time. There are provisions in the machine to attach the ECG, the ECG that inlet. Either you can attach it to the multipara on the baby's head in the baby warmer. You can attach your machine with that. The ECG tracing on the multipara can be seen running in the in your echo machine, or you can directly attach the leads of the ECG in the echo machine. But for the normal clinical studies, we don't use it. Maximum people, 99% people, they don't use that. Then this is the image, or this is the Doppler scale. This is a color window. This is a probe orientation marker. I've explained to you. Now, we will talk about the depth also, but we say the image is optimized when this whole sector is there. Dr. Kamal has explained to you yesterday also, when he was explaining the depth, that the organ, the structure should cover at least 60 to 70% of the sector. Okay, should cover at least 60 to 70% of the sector to make it big enough to be seen clearly. And the other thing is, this dead space should be minimum. More is the dead space. This is your dead space here. This is your dead space. More is the dead space, more will be the artifacts. Lesser is the dead space, lesser is the artifacts. That's why we say that the organ of interest should cover at least 60 to 70% of the sector. So in that case, your dead space will be less and your artifacts will be less. Okay. So to make the image optimized, these things have been explained to you. We should use the button depth. Depth, what it does, it brings the organ closer to the probe, and hence make it big. The resolution is good and more clear. Gain, yesterday and day before yesterday, it has been explained. It is basically a contrast between black and gray. Black is the liquid or the blood, gray is the solid, and more dense is the tissue, more white or gray the tissue is, less dense the tissue, less white and less white the tissue is. Okay, and then the color, when you put, you will see the color flow in that color window. So my question to you people is, you can write in the chat box or you can unmute and speak. what what the red color represents? What do you mean by red flow and what do you mean by blue flow? Anyone? Part. Great. So blue away and red towards. Very nice. Good. So then M mode, motion mode. Dr. Sajan has explained you very well. Okay. Then in Dopplers, there are three types of Dopplers. The three types of Dopplers are color Doppler, pulse wave Doppler, and continuous wave Doppler. These buttons will be there for up and down movement of this probe orientation markers, so that can be very well seen and done in the physical hands-on sessions. So the Dopplers, he must has been explained: pulse wave Doppler, continuous wave Doppler, and the color Doppler. So my question to you is, when you should use pulse wave Doppler and when you should use continuous wave Doppler? You can write down in the chat box. Yes. So good. So the thing is, for all measuring all type of velocities, for measuring all type of velocities, so for measuring all type of velocities, you should use the pulse wave Doppler. Pulse wave Doppler to measure all type of velocities till the peak systolic velocity. The peak velocity is less than 2 meters per second. Okay. Theoretical it is 2 meters per second, but many machines, like in my machine, if your peak velocity, the upper range reaches 1.6 or 1.8 meters per second, then the phenomena what we call as aliasing. There is a phenomena what we call as aliasing. Aliasing. That phenomena of aliasing starts. Okay, or what we call as Nicosia effect. Nicosia effect will start. So in that case, if your peak velocity is more than 1.8 or 2 meters per second, you should switch over to continuous wave Doppler. From pulse wave Doppler, you should switch over to continuous wave Doppler. Okay. So for measuring all velocities anywhere, start with the pulse wave Doppler. If your peak velocity increases more than 2 meters per second and you start seeing Nicosia effect or aliasing, you switch over to continuous wave Doppler. Only in case that you want to measure the tricuspid regurg or mitral regurg, that is regurgitant jet through the mitral valve or the tricuspid valve, then in that case you should use the continuous wave Doppler and not the pulse wave Doppler. Okay, remember this. This is very important. So pulse wave Doppler, in pulse wave Doppler, you can identify that particular region in which you do the measurement of the RBCs, but this is a pulse wave Doppler, so you will be able to measure the velocity of the RBCs within this range gate. Okay, so it will measure the velocity of RBCs only within this range gate and ignore if the RBC is above or below this. Okay, so in that case, this is the limitation, but the uniqueness of this pulse wave Doppler is that very specifically for that particular area, you will be able to measure the velocity of the RBCs in that particular area or range gate. This is the range gate. In continuous wave Doppler, what it does, it measures the velocity of all the RBCs along this sector and gives you the average out of it. The upper limit is 2 meters per second. Here in new modern machines, it can go till 20 meters per second. But normally, whatever the make of the machine is, the upper limit is limited at 15 meters per second. Okay, so that is the upper limit in continuous wave. So this is aliasing effect. See what we are doing. This is the Dopplers of the pulmonary artery. This is systolic, and what I've done is I'm decreasing the range artificially. I brought it 0.6. You can see the tip of this velocity. This tracing has been broken and is broken in the brought in the opposite side. So it means the maximum velocity that we are measuring is more than the range till this particular range can measure. So it will start perceiving that it is coming from the opposite side. So that is aliasing. So in that case, the maximum range pulse wave Doppler can measure is 1.8 or 2 meters per second. So if your peak velocity is more than that, then you have to shift over to the continuous wave Doppler. Okay, and this Dr. Kamal has showed you probe marker corresponds with the probe orientation marker, and he also showed you the sidedness, how this can move, but the structures on the side of this probe marker will be shown on the side where you have this probe orientation marker. And we all know by convention, this probe orientation marker is always on the left side of the screen. So those structures will be shown on this side of the echo screen. This you know, but very well, very nice. So we come down to the windows. Windows, I've told you, through which we will see the various structures. If you go and get trained with pediatric cardiology or adult people, they always start with the subcostal windows, and that is scientifically, and the approach is correct. But in neonatology, so if your babies are on CPAP or in room air, so if you start with the subcostal views directly, it irritates the baby, and the babies, they start crying, and you will not get the proper. So that's why we tend to do the subcostal views in the end. So whichever window you choose, the only thing you should remember is you should complete the whole sequence so that you cover all the views and structures and you should not miss it. So that's why whatever approach you choose, from apical or subcostal or whichever, you should keep doing that approach. So one is apical views. Okay, so that is just below the nipple in the mid clavicle line in fifth and sixth intercostal space. So there you see the apical views of the heart. This is apical window. Then you have parasternal views. So parasternal views are divided into two: low parasternal, high parasternal. So this what I am drawing is nipple line. These are the two nipples. Okay, here, and this is a nipple line. And then you have a sternum. This is your sternum. This is your sternum. Okay. So the views which have been taken from nipple line and below, that is a lower 1/3 of the sternum, are known as the parasternal, low parasternal views. So parasternal views are then divided into two: low parasternal, nipple line and below, or lower 1/3 of the sternum, and high parasternal views, that is above the nipple line or in the upper 2/3 of the sternum. So you have parasternal views. So one is apical views, and then you have parasternal views. Parasternal views are two: low parasternal and high parasternal. Okay. Then you have suprasternal notch, that is for the aortic arch view. That also comes in the category of high parasternal. And then you have the subcostal views, that costal just below the Z fistula. So if I classify your views, so it will be, the first one will be the apical views. Okay. First one will be the apical views. Then you have the parasternal views. Parasternal views are divided into two. One is low parasternal and low parasternal, a nipple line in below in the lower one third of the sternum is low parasternal, and then you have the high parasternal. High parasternal are the ones nipple line and above in the upper two-thirds of the sternum. So that is a high parasternal views. And then in the end, you have subcostal views. So you have apical views, parasternal views. Parasternals are subdivided into two: low parasternal, high parasternal, and the subcostal views. So that's how we divide the windows or the views of the heart on the baby's chest. I hope it is clear. The windows are clear to everyone. If yes, some of you may write yes in the chat box. Then only I will move ahead. Until and unless you are clear with this, it will be difficult for you to understand in the further presentation. Great. Good. Nice. So whenever we start doing the views, it is always good and easy to imagine a clock in front of the baby. Head end is 12 o'clock. Left shoulder, left side is 3 o'clock. Right shoulder, right side is 9 o'clock. And the foot side is 6 o'clock. 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So henceforth, whatever video I will be showing you, yeah, in that I will be talking that where I am going to keep the probe marker, where I will direction of probe marker, I will speak in terms of o'clock so that it is easy for you to understand and it maintains the uniformity. Focus and all we have talked about. Whatever views we do, the first thing starts with the 2D view. So this is your B mode or 2D view. Anybody can tell which view is this? This one? This is 2D view. Which window and which view is this? Apical floor chamber. Very good. Great. Nice. Then we have the color. We put a color window and we do that. And the other mode is the M mode, that is a motion mode. We use this to calculate the size of the structures and even to calculate the contractility of the heart. Okay, so this is how we will be using it. So first we'll start with the apical four chamber views, and then I will be telling you that sweep movement of the probe. So everybody just concentrate on my on. You can open my this thing camera. Okay. Now see, this is my probe. This is the foot of the probe, and this is the tail of the probe. This is the skin. This is surface of the baby. Okay. First, we will discuss this when we come for the hands-on training. Try to hold the probe so that you rest the two fingers on the baby's chest to stabilize the probe. Okay. So this is the foot of the probe. So we have three basic movements of the probe. One, so this is the probe and the ultrasound waves are arising like this from this. Okay. When the probe moves with the plane of the ultrasonic waves like this, this is known as sweeping movement or the tilt, sweeping movement of the tilting movement. When we move the probe like this, it is known as the rotating movement. And if we move the probe like this is known as angulation. In this, the foot of the probe moves at right angle perpendicular to the plane of the ultrasonic waves. If the probe moves like this, it is tilt or sweep. When we say sweep up, it is always the foot of the probe. Sweep up, sweep down, foot of the probe. Rotation and angulation. So you should remember this. Okay. So I'll start with the apical four chamber view. Then we have the sweep in that, sweeping movement. So now in next few slides, first try to concentrate on this part of the slide. This part of the slide. There you will see a video that how to keep the probe on the baby's chest. Then you concentrate on this part of the slide where you will see the video of the structures you will be seeing where you have kept the probe. And then there will be a fixed picture which is labeled when the various structures are labeled. So there are three parts of the slide. First, you concentrate on part 1, part 2, and then part 3. Okay. So here what we are doing is a apical four chamber view. The probe is being kept below the nipple at the apex around 4th to 5th intercostal space. Probe orientation marker is facing at 2 to 3 o'clock. That is towards the left shoulder, 2 to 3 o'clock position. And here you can see the probe orientation marker here is down. So this is what we call as a apical four chamber view, which is upright, anatomically corrected. Why? Because see, whenever I see a heart, imagine a heart in the chest lies like this. Okay. So your ventricles are towards the probe. So here is your probe. The probe is here. So I always imagine the heart like this. So I always imagine the heart like the ventricles down towards the probe and atria above. So this is how I have always imagined the heart. So that's why we call it a anatomically corrected. But in adult, they always do this apical four chamber view by bringing this probe orientation marker up here. So that is inverted four chamber view. But in pediatrics and neonatology, we do the apical four chamber view anatomically upright. That's why we tend to keep this probe orientation marker down here. Probe is here, just below the nipple, pointer pointing at 2 to 3 o'clock position. And this is your LA, LB because the pointer is towards the left side. RA, RB, interatrial septum, interventricular septum. This is mitral valve, and this is tricuspid valve. Here you are seeing the descending aorta. Why the descending aorta is seen like this, cut cross-sectionally as a black structure hole. I will show you when I will show you the animation because it wraps around the heart and goes down. So when I cut the heart like this, it is seen like this. And I am seeing these three pulmonary veins, 1, 2, and 3, which are entering into LA. So this is my apical four chamber view. And then, so what I told you, what I've done is I have rotated the probe from 2 o'clock to 3 o'clock, and I've swept the probe anteriorly, that is upwards, anteriorly. So what I've seen is four chambers are there, LA, LB, RA, RB, interventricular septum, but this fifth chamber has opened up. So this is your aorta, and this is your aortic wall. So this is known as apical five chamber. The probe is at the same position, that is the apical window. The only thing is for apical four chamber, it was facing at 2 o'clock. I've slightly rotated the probe from 2 to 3 o'clock and swept the foot of the probe upwards anteriorly. And anteriorly, this aorta has opened up, and this is known as apical five chamber. So this is how the heart has been cut. So this is ultrasound probe. These are ultrasound waves. They go up and then they cut the heart upside down and bring it in front of. And now you see the aorta in this. This aorta is going up and wrapping around your atria and going backwards. So when it gets cut, so this aorta, which is wrapping backwards, is being cut like this and shown like this. So this is a four chamber LA, LB, RA, RB, pulmonary veins and aorta. And then you have this. I will show you that sweep. When you sweep anteriorly, you will have this five chamber view. How it happens, I will show you in one animation. and then you put the colors across the valves. So anybody can tell which we are seeing the color Doppler across which valve? Tricuspid valve. Very nice. Great. Okay. So then the blood flowing from RA to RV, what will be the color of that blood? RA to RV? What will be the color of the blood flowing from RA to RV? Red. Yes, it is moving towards the probe. And then what will be the color of TR jet? So this is the red color. Blood is flowing from RA to RV. Here is your probe, so it is towards the probe. And TR jet will be the blood moving from RV to RA away from the probe, and so it will be blue. Very good. Very nice. Good. So here I am similarly doing the Doppler of the mitral wall. So blood flowing from LA to LV will be red and the MR will be blue. Okay, blue, very nice. We have all understood the previous lessons, the previous presentation, this one very nicely. Great. So this is your blood flowing through your apical 5 chamber. And this is again, I further sweep the probe anteriorly. There was a 5 chamber view, and that has been gone. And then anterior to that, to a right angle to it, there is another vessel that has come perpendicular to it, that is pulmonary artery. And sometimes we call it apical 6 chamber view. So we have apical 4 chamber view. Sweep the probe anteriorly, you will have apical 5 chamber view. And if you sweep the probe more anteriorly, it will be apical 6 chamber view. See this. So this is your, when I do this, this is a cross section of the heart, cut heart. This is your LA, LV, mitral valve, RA, RV, tricuspid valve. So this is your LV cavity. This is your RV cavity, interventricular septum, and this is your LA and RA. Now, if I sweep the probe anterior, and now you can see anterior to the LV cavity is your aorta. So when I sweep the probe anteriorly, so from 4th chamber, this 5th chamber, that's aorta, it can be seen. So you see this aorta going out of LV, and this is a aortic valve. Okay. And when I sweep the probe more anterior to that, what happens? Anterior to aorta is your pulmonary artery. And you can see this pulmonary artery and aorta, they are in different planes. Pulmonary artery is anterior to this aorta and is at right angle. So when I start seeing this pulmonary artery in the structure, aorta is gone. Okay, so pulmonary artery is right angle and anterior to aorta, and then you start seeing the pulmonary artery. So this is your more anterior sweep. So in a apical window, you have apical 4 chamber view, apical 5 chamber view if you sweep the probe anteriorly. And if you sweep the probe more anteriorly, you will stop seeing that aorta, and right angle to that, you will start seeing this pulmonary artery. And that sometimes you call it apical 6 chamber view. So that's how, with this animation, you will understand that how this anterior placement of aorta from LV cavity and anterior at right angle placement of pulmonary artery to aorta. So that's how your interior sweep of the foot of the probe creates 4 chamber, 5 chamber, and 6 chamber. So now if you sweep from 5 chamber to 6 chamber and you see this crisscross of these two vessels, what congenital heart disease it rules out? Anyone? TGA. Very good. Good. Yes. So it rules out because if there is a TGA, then both these vessels will be in the same plane. So this is your apical 4 chamber, 5 chamber, and 6 chamber. So that completes your apical views. And then we come to the low parasternal views. In low parasternal views, see, parasternal views are divided into two: low parasternal, high parasternal. In low para, now we will talk about low parasternal, that is nipple line and below, in the lower 1/3 of the sternum. And in low parasternal, you have two subcategories, parasternal long axis and parasternal short axis. In long axis, the ultrasonic waves will cut the heart in longitudinal axis. And in short axis, the ultrasonic waves will cut the heart in cross section. So we'll talk about long axis, parasternal long axis view. So now you see, we keep the probe at the nipple line where the pointer probe oriented marker is being pointing at right shoulder, or what we call as 11 o'clock position. Here you see the probe orientation marker is up here, and it has cut the heart up longitudinally from anterior to posterior. This is your RV wall, interior wall, RV cavity, interventricular septum, LV cavity, posterior wall of LV, aorta, aortic valve, LA, left atrium, and mitral valve. So main structures to be seen in parasternal long axis, what we call a standard plex view is RV cavity, interventricular septum, LV cavity, aorta, aortic wall, LA, and the mitral valve. So these are the few structures that we should concentrate and see in the parasternal long axis. This is how it is. There is a heart in the chest of the baby. Probe is being pointing at 11 o'clock position, and the yellows are the ultrasonic waves going from the probe. And this is how the parasternal long axis is being cut. RV, interventricular septum, LV, LA, and this is aorta and aortic valve. So this is how longitudinally the heart is being cut, like this. So the heart is being cut longitudinally and produced in front of you. So that is your parasternal long axis view. Okay. And we are doing the color Dopplers and seeing the any defect in the interventricular septum. And there we do the M mode and all that to do the functions, calculate the functions by calculating the diameter of LV in diastole and systole. We talk about later. And now in this, you will see we do the two sweeps in this parasternal long axis view. One sweep is towards the foot, what we call as the tricuspid valve sweep. Here you see we have swept it towards the foot. You see this tricuspid valve. So this is tricuspid valve sweep or RV inflow sweep. Then again, the probe will be brought at the standard. This is standard plex view, parasternal long axis view. Then we sweep up towards the head, up towards the head. Then again, you see in this that when you sweep it towards the head, see in this parasternal long axis standard view, you see this aorta, which is horizontal. When we sweep the probe up towards the head, you see that aorta, which was horizontal like this, is gone. Instead of that, you start seeing a vessel vertical to the aorta coming from up, down, upside down. See, so this is your main pulmonary artery, MPA. And here you see this is getting divided into two branches. So this is your MPA, this is your RPA, and this is your LPA. MPA, main pulmonary artery, RPA, right pulmonary artery, and left pulmonary artery. So now what you're seeing is that your aorta, which was there, is gone. And then vertical to that, you started seeing this MPA, RPA, and LPA. So this is, again, this sweep rules out your TGA. Okay. So these are the two sweeps, and this sweep down is known as tricuspid valve sweep or RV inflow sweep, and sweep up is known as pulmonary artery sweep or RV outflow sweep. So these are the two sweeps we do in the parasternal long axis view. Okay, like this. Sweep up, that is your pulmonary artery sweep. MPA, RPA, and LPA. We have put a color. Sweep down towards the foot. This is your tricuspid valve sweep. Here we can see again the tear jet is blue because it will be moving away from the probe. we can calculate the TRZ here. The next thing is, so this was parasternal long axis view. So that is again a part of no parasternal views. So now we will see how we attain the short axis view, in which the heart is being cut in short axis. Here you can see from 11 o'clock, I have rotated the probe to 1 o'clock. That is from the right shoulder towards the left shoulder. So at right angle from where I was getting the parasternal long axis view, same place I will keep the probe, but from 11 o'clock, I will rotate it to 1 o'clock. So I will cut the heart in cross section at the base of the heart. Base of the heart is a place where the atria and ventricles, they join each other. So that is the junction of atria and ventricles. So that is a place from where the root of aorta starts. So that's why the section that you will see will be here is the aorta has been cut in cross section at the root. So at the root, you will see the tricuspid valve. So here you will see, this is your aorta in cross section, and you have this aortic valve cusps. There are 3 cusps. So that's why it is also known as Mercedes-Benz sign. You can see this is like a Mercedes-Benz sign. So this is your aorta in cross section with 3 cusps. This is the pulmonary artery on the left side of the baby with this pulmonary valve. It is arising from the RV, right ventricle, and this is your tricuspid valve. This is your RA, right atrium, and then at the base here is the LA, left atrium. This is the interatrial septum. So this is aorta in cross section with 3 cusps: pulmonary artery, pulmonary valve, RV, tricuspid valve, RA, interatrial septum, and this is left atrium. So this is your parasternal short axis first section. So that is your Mercedes-Benz sign view. This is being cut in cross section like this. Here, the heart is being cut in cross section at the base, and this is your Mercedes-Benz sign view. And then we sweep this probe from the base. This is the base of the heart, where the atria and ventricles are at the junction, and this is the root of the aorta. From there, we sweep the probe, ultrasonic waves, to the tip, apex of the heart. So the next thing, when we travel from the base of the heart at the root of the aorta through the LV towards the apex, the next thing that I will encounter, the structure that I will encounter, will be the mitral valve. So see, I am sweeping the probe from the base of the heart towards the apex of the heart, like this. So this is your fish mouth view or mitral valve. This is the mitral valve. This is LV, interventricular septum, RV. Okay. So this is your LV. This is your mitral valve, fish mouth view. This is your interventricular septum. And this is your RV. RV, interventricular septum, LV, and this is a mitral valve. And this is known as the fish mouth view. As you can see, this mitral valve is opening and closing like a fish mouth. And then when I sweep it further down towards the apex, the next thing will be the papillary muscle view. Again, this is LV cavity, interventricular septum, RV, and these are the papillary muscles. And if I sweep the probe more further down towards the apex, I will be seeing that which is the apex forming chamber. It is very important to determine which is the apex forming chamber, because it rules out your hypoplastic left heart syndrome, because always your apex is formed by the LV until unless hypoplastic left heart. And when we will show you in the hands-on workstations, that when we sweep the probe towards the apex, your RV will be gone, and you will see the apex will be formed by this LV. And this is the LV cavity. So this is your apex forming chamber is left ventricle. We have to determine. This I am doing the Dopplers of the interventricular septum in parasternal short axis view. So that's completes your low peristernal views. So till now what we have discussed apical views in which we have two sweeps, which is sweep of the foot of the probe is swept anteriorly, we get apical 5-chamber view. And then we sweep the probe more anteriorly, we go to apical 6-chamber or pulmonary artery. Then we come to the low peristernal views. Low peristernal views, first is peristernal long axis. We have two sweeps in that, sweep downwards, that is towards the foot, is tricuspid valve or RV inflow sweep, and sweep up towards the head is your pulmonary artery or RV outflow sweep. Then we rotate the probe from 11 o'clock to 1 o'clock at the same nipple line. We cut the heart in short axis in cross section. We start from the base of the heart, so we get a cross-sectional view from the root of the aorta, and that is what we call as Mercedes-Benz view. And when from there we sweep the probe downwards towards the apex, we come to mitral valve or fish mouth view. And we sweep further down, we come down to papillary muscle view. And then we sweep further down towards the apex to look which is the apex forming chamber. So these are the 4 sweeps in peristernal short axis view. And now we come down to the high peristernal views. High peristernal views means above the nipple line or upper 2/3 of the sternum. But most of the views are in the upper 1/3 of the sternum. Okay. For you people, like in the basic course, we discuss that there are 6 views in the high peristernal views, but we will be discussing ductal view, pulmonary artery view, pulmonary vein view, and aortic arch view. Okay. Aortic arch view, pulmonary vein view, pulmonary artery view, and the ductal view. So to understand this, you should remember one thing. Suppose this is a baby head, neck. This is the baby's chest. This is suprasternal notch. This is the sternum. This is the clavicle here. Okay. So to understand the orientation of the vessels, from right to left, this is the baby's right and this is the baby's left. From right to left, the orientation of the vessels is most right is SVC. Then next to that is ascending aorta. Next to that is, so this is right is SVC, and this just right to the sternum is ascending aorta. Then behind the sternum or just left to that is the pulmonary artery. And then left to that will be the descending aorta. So anybody can repeat? You can write in the chat box which is the most right. Most right. SVC, yes. And then left to SVC is ascending aorta. And then left to that is, yes, left to the ascending aorta is pulmonary artery. And the most left to that pulmonary artery is descending aorta. Very nice. Great. So just remember this. So for arch of aorta, we generally, adult and pediatric people, keep the probe in suprasternal notch. But in newborns, it is very difficult to keep the probe in the suprasternal notch because it is very small. And if the baby is on the ventilator or so, it is very difficult to fit in the probe in the suprasternal notch. So we do it from the right subclavicular area. See why we say it's subclavicular, because most of these views are in the upper one third of the sternum, upper one third of the sternum. So right of the sternum, this area, the area upper one third and right of the sternum is this one. So this is basically a subclavicular area. So we keep the probe in the right subclavicular area, and for the ductal, pulmonary artery view and pulmonary view, we keep it in the left subclavicular area. Here. Okay. So what is the orientation of the probe marker and all, I will just show you. So we will be discussing ductal view, pulmonary artery view, pulmonary vein view, and the aortic arch. These views we will discuss. Okay, the ductal view. As we have seen, see, the thing is, duct is the structure between pulmonary artery and descending aorta. And we have discussed the pulmonary artery and descending aorta are on which side of the sternum, right or left? Left. Great. So that's why we keep the probe on the left subclavicular area, pointer pointing at 12 to 1 o'clock position. Pointer pointing at 12 to 1 o'clock position on the left side of the sternum. That is a left subclavicular area. So this is also known as the modified short axis view, in which we have the pulmonary artery and descending aorta, because PDA is a structure which is joining descending aorta to the pulmonary artery. And here you see this is a pulmonary artery and this is your descending aorta. If the PDA is there, the PDA will be a structure joining descending aorta and the pulmonary. So that's why we have to keep the probe on the left side so that we can see pulmonary artery and descending aorta both. And if there is a PDA, this is a structure. And the blood flow in the PDA, if it is left to right, that is from aorta towards pulmonary artery. And as you can see, it is towards the probe, it will be red. So the blood shunting from PDA, if it is left to right, it will be red. And if it is right to left, that is pulmonary artery to aorta, what will be the color of the flow? Anybody? Blue. Yes, good. Because it will be away from pulmonary artery to aorta. It will be away from the probe. So that's why it will be blue. Good. Okay. So here you can see probe is kept in the left subclavicular area, pointer pointing at 12 to 1 o'clock position. So you see this duct. So is there any duct in here? So these two, pulmonary artery flow and descending aorta flow, are blue. Okay. Is there any PDA in here? Are you able to see any PDA here? No. Great. And here, is there any PDA here? Yes, there is a PDA. It is shunting left to right. Good. And now the arch view. The arch view, we do it from the right subclavicular area, not from the suprasternal notch. Pointer again pointing at 12 to 1 o'clock position. Probe orientation marker here. This is the ascending aorta. This is the isthmus. This is the transverse aorta arch, and this is a descending. Ascending, transverse, and descending arch. And these are the three branches of aorta, 1, 2, and 3. And what you are seeing here is the RPA, right pulmonary artery, because when the aorta and pulmonary artery, they are right angle to each other, and it so the aorta is moving like this, wrapping like this. Pulmonary artery is divided and gets cross the aorta like this. So when you cut the aorta longitudinally, this pulmonary artery RPA will be cut cross sectionally. So that's why you see the pulmonary artery RPA like this. Okay. So this is the arch that is done from the right subclavicular area, pointer pointing at 12 to 1 o'clock position. Reading the Dopplers. And then the pulmonary artery view and pulmonary vein view again from the left subclavicular area. But here you will see In ductal view, we did it from the left subclavicular area, but the pointer was pointing at 12 to 1 o'clock position. In this pulmonary artery view, the pointer is pointing at 3 o'clock position. Here is the probe orientation marker, and you see this pulmonary artery, MPA, RPA, and LPA. MPA, LPA, and RPA. This is aorta in cross section, and this is your SVC. This is right, this is left. So that's why SVC, aorta, pulmonary artery. And you can see the aorta in cross section is on right and posterior to pulmonary artery. This is important because this is a normal relationship of pulmonary artery and aorta. If normally the aorta in this view is always right and posterior to the pulmonary artery. If your aorta is interior or towards the left of the pulmonary artery, that means it is a TG. Where you keep the probe? We keep the probe in the left subclavicular area here, pointer pointing at 3 o'clock, and this is the pulmonary artery. And then what we do is we keep the probe there at 3 o'clock and sweep it down, sweep the foot downwards. What happens is the LA, left atria, just behind the pulmonary artery gets opened, and then you will see 4 pulmonary veins entering this LA. This is the right, this is the left. Sorry, this is the left, this is the right. This is the right lower, right upper, left lower, left upper. When I put a color, and this is a venous flow, I have to bring down the velocity scale to 0.25 to 0.35. You will start seeing this pulmonary venous flow. See, this red one is left lower, this blue one is left upper, right lower is red, and right upper is blue. Why the upper ones are blue? Because the blood flow in these upper ones, this is a probe. This is away from the probe. So that's why the upper ones are blue, and these lower ones, the flow is towards the probe, they will be red. So that's why the flow in the low, both right and left lower veins is red, and right and left upper veins is blue. So this is also known as your crab view. This is also known as the crab view. It looks like a crab. So there is a pulmonary venous. So there is a pulmonary vein view. So we have discussed 4 high parasternal views. One is arch view, which is to be done from the right subclavicular area, pointer pointing at 12 to 1 o'clock position. You see the arch with 3 branches. And then 3 views we did from the left subclavicular area. One is ductal view, where the probe is being kept in the left subclavicular area, pointer is pointing at 12 to 1 o'clock position. Then we have pulmonary artery view. Again, it is from the left subclavicular area, but here the probe pointer is pointing at 3 o'clock. You see pulmonary artery, aorta, and SVC. And aorta is towards the right of the pulmonary artery and posterior. And then we sweep the probe from there, keeping the probe orientation marker at 3 o'clock downwards. Then just below the pulmonary artery, your LA opens up, and in your LA, there are 4 pulmonary veins which are entering, and this is known as the crab view. So this is your pulmonary vein view. So we have discussed arch view, ductal view, pulmonary artery view, and the pulmonary vein view. Now we have come down to the subcostal views in the end, because it irritates the baby. So there in subcostal views, we have 2 ways. One is cross-sectional and one is longitudinal. In cross-sectional, the probe is being kept just below the xephisternum, and the probe marker is pointing at 3 o'clock. There we see we determine the side, that is known as the side orientation, whether there is gastric shadow is on the left, liver is on the right, IVC is on the right, and aorta is on the left. So the situs is maintained. So that is your situs view. And then we sweep the probe bit up, we go for the atrial view, atria. in which we see the interatrial septum and two atria. In longitudinal views, we look for the IVC where it enters the RA and we see the abdominal aorta. So these are the longitudinal views. So here, first what we are doing is atrial view. We have kept the probe just below the Ziegfeld sternum, pointer pointing at 3 o'clock. Here, again, I bring the probe orientation marker down here. So the atria which is closer to probe is right atria. So this is RA, LA. You can see this pulmonary veins entering this atria. So that's why it is LA. This is the interatrial septum. And here you can see the flap also. So this is your PFO. If you have a flap, it is patent foramen ovale. If you do not see a flap, the cut edges are sharp, well defined. It is AST. So this is your RA, LA, interatrial septum, flap. So this is your atrial cross section. Then we have the longitudinal. Here we keep the probe again in the subcostal area, pointer pointing at 12 o'clock. If we sweep towards the right side, we will see the IVC. This is the liver. IVC through the liver, it is entering into RA, and this is a hepatic vein. We use it to do the collapsibility percentage of IVC to judge the preload, whether the baby is in shock or not. Yes. Pointer pointing at 12 o'clock, ultrasonic waves, we sweep it towards the right side. Get to see this. This is IVC. Whenever the IVC enters into liver, RA, it always fans out. This is what I showed. And when I sweep the probe towards the left, on the left you will have aorta. This is abdominal aorta, and these are the two branches, celiac and SM. Celiac and SM. This is abdominal aorta. Okay. So different views, different this you will understand in the end when you will finish out all the indices. So you will have apical views in which you have apical 4 and 5 and 6 chamber view. Then you have low parasternal views in which you have parasternal long axis with two sweeps, pulmonary artery sweep and tricuspid valve sweep. Then you have the short axis, parasternal short axis view, where you keep the probe marker towards 1 o'clock, and you have four sweeps. One is Mercedes-Benz sign, other is mitral valve, that is fish mouth. The next sweep is capillary muscle sweep, and the last is apex forming chamber. Then we have the high parasternal views in which we have on the right subclavicular area as an arch view. In the left subclavicular area, we have the ductal view. And in the left subclavicular area at 3 o'clock, we have pulmonary artery view. And then sweep down by keeping the probe at 3 o'clock, pulmonary vein. And then in the end, we do subcostal views. Again, in that, we have transverse and longitudinal. In transverse, we have situs view, atrial view, and then longitudinal, we have the IVC, and then the abdominal aorta. So these are the views in nutshell. There are many specialized views, but this is a basic workshop. So that's why I have stick to only to the basic views. We do run the courses. If anybody is interested, can email or send a message on this number. And we do have the books. If you are interested, I can share the link. You can get this books and you can read through that. I will also share in the group, I will share the manual, which will be good for you. If you go through that, you go through the recordings, you go through the manual, and when you come for the hands-on, it will be easier for you to understand, and you will utilize that time much more better. And that manual is not in detail, but it will give you the outline. So thank you very much for attending this. If you have any questions or anything to ask, you